Good evening, everyone. Thank you all for coming. I'm Supervisor Nick D'Alessandro, and I'd like to thank CAPE for being here in East Fishkill. I'd like to thank everyone who will be part tonight in our panel. Elaine Repetto, our CAPE Director. Jessica Siriani, she's a CAPE Counselor for Roy C. Ketchum High School. Kevin Keefe, our Chief of Police in East Fishkill. Staff Sergeant Julio Fernandez from the New York National Guard. Jean-Marie Nyber, she's a coordinator of prevention services at Dutchess County Department of Behavioral and Community Health. Cynthia Mejorado Flint, she's the Public Relations and Communications Associate at High Watchtower Recovery Center. Eric Dentrone, Associate Director of Regional Services for Arms Acres. James Hughes, Lexington Center for Recovery. Eleanor Riley, she is the John Jay High School Assistant Principal. Megan Gerard, she's the CAPE Counselor at John Jay High School. Lisa Bennett, one of our local parents. Dominic Tuminaro, I don't see him yet.
He said he finishes at 7.
Okay, he will join us in a little bit. And Megan Hatfield from the CAPE Recovery, she's a CAPE Recovery Coach. Thank you all very, very much. We appreciate you being here. These community conversations are so very important to us. You know, if you want some information and advice, our goal is to provide it for you. That's why we're all here tonight. Drug addiction is a very complex disease, and many people don't understand it. Drugs change the brain in ways that make quitting hard for even those who want to try and quit. Fortunately, people like the ones we have here tonight know that better than ever how drugs affect the brain and know treatments that can help people recover from drug addiction. So I'm very thankful you're all here. I'm very excited to get started with the program, and our community is happy that you're here, and I'm sure we're going to do many of these in the future. I'd like to introduce our Chief of Police, Kevin Keefe.
Thank you, Mr. Supervisor. I just want to start by saying that the town of East Fishkill is represented in the CAPE's Southern Dutchess Community Coalition, which is a coalition of all these fine people here, as well as other people in the community that come together, and it's almost like a think tank of ways to try and help educate the public and things we can do better to help tackle this disease, and how to find ways to do prevention as well as education, because you can have all the treatment on one end of the spectrum, but if you don't have the prevention and the education at the other end, we're never going to make it to the middle of the core of the problem. So I'm just very proud that East Fishkill is well represented in our coalition, and we've got a long history working with CAPE, and they've provided us with a lot of good resources over the years, and we're just happy to continue working with them. So I'll turn it over to Elaine Repetto, our Executive Director.
I am not a digital native, so it will. There you go. Okay. Good evening, everyone. I see some familiar faces in the audience. I have a lot of nervous energy, so I tend to walk around. We have lots of really informed people here this evening. So what I want to do is give you a brief backdrop surrounding the topic that we're talking about tonight. I have strong suspicions that those of you who are here come with some level of information about the disease of addiction to begin with. So what is this problem, and how does it affect our area? Well, it doesn't just affect our area. It is a local, regional, state, and national problem, as I'm sure many of you are aware. What makes Dutchess unique? In 2014, we were designated as a high-intensity drug trafficking area by the New York, New Jersey group, who take a look at designating areas that are at high risk. I will say that since 2014, there are many, many areas throughout our country that have that designation. I'm sure all you have to do is flip on the news, and you're well aware of the problem before us. So why are we geographically predisposed to having this problem? Well, let's think about it for a minute. We're equidistant between New York and Albany. We have 2 rail lines on either side of our county, and we are intersected by multiple high-traffic roadways that have close proximity to the I-95 corridor, which runs from Florida to Canada and back the same way down, and that is, on the East Coast anyway, the high-traffic area for drug distribution. So we are in a unique geographical position. That being said, in 2014, because of that designation and because of the fact that we had been working as a coalition for some time, we were awarded a federal grant by the Substance Abuse and Mental Health Services Administration. It's called a Drug-Free Communities Grant. And I'm fortunate to have one of CAPE's former employees here who's now across the river with Catholic Charities, who was on the front end of that grant in 2002, I think, if I'm not mistaken, Dawn. So it was a two-part grant, 10 years in duration. We are in year 8, so we're winding down with that grant. What that grant does is it hopefully builds awareness around the topics associated with risks that affect our young people and our families. And that's why we're here tonight, to talk about those things. All of these lovely people who are behind the table this evening are here, as you heard Kevin mention earlier. They are part of the folks that CAPE works with on a regular basis, and each of them play a distinct role in the kinds of solutions that our county is bringing to the table to address this problem. A statistic that I found very telling, 2 statistics. In our county, between 2016 and 2017, and Jean, correct me if I'm wrong, our county saw a 35% increase in overdoses in Dutchess. That trend is continuing upwards. It is not unlike other counties and other states in our nation. As a matter of fact, some of you may be aware that the president issued a dictate to put together a federal commission to take a look at the addiction problem in our country. And as a result of that commission's findings, what we know is that every 3 weeks, we have overdoses in our country equaling a 9/11 event. That puts it in perspective. With that being said, just to give you an overview of what's going to happen this evening, we're going to have each of these folks bring their particular perspective to the solution end of this problem. Because while we see a lot of the sensational information attached to the disease of addiction, it's very often slanted, and it's slanted in ways that perhaps can be ill-informed and can attach some ignorance and prejudice to this disease. We want to dispel those things because, as you heard Kevin and our town supervisor mention, this is a complex brain disease. So when you leave here tonight, that's the message I want you to leave with. I also want you to be able to know the resources that are available to you locally and throughout our county. So with that, we're going to get started. As you can see, we have quite a little army of folks behind that table. So they each have their marching orders in terms of they're going to take a brief amount of time to introduce themselves and to tell you what's their affiliation with the organization they represent and a little bit about the work that they do. I would also like to call your attention to the information that is outside. Please feel free to take that with you. It's information that will help you flesh out a broader understanding of the disease, the drugs that can be involved, the services that are available. Once we have everyone give you a little bit of insight into who they are and what they provide, we will have some time for a Q&A. And then we will move over to our New York National Guard partner, who's kind enough to be able to provide a Narcan training for those who have signed up and wish to be able to leave here this evening with that training and with a kit. Any questions so far? I've put you all to sleep, right? Okay, with that, we're going to start with probably one of the most important groups of people that certainly CAPE works with, our counselors work with, and many of the folks at the table here work with, and that's our parent community. So I would like to introduce you to Lisa.
Will this one work?
Yes, it does, Lisa. And I think there won't be any feedback if I put it there.
All right. I'll read for a little bit because I usually cry. Hi, my name is Lisa Bennett, and I'm a parent of loss. I am a parent forever impacted by the disease of substance use disorder after losing my 22-year-old son, Jeff, on December 5th, 2016. Jeff had struggled with his disease of substance use disorder for 4 years and had only achieved recovery in his final year when he had access to medication-assisted recovery. Excuse me, medication-assisted treatment, and that was a drug, Vivitrol. While in recovery and with a lot of hard work, Jeff had many successes, including returning to college. However, without fully engaging in the recovery support services available to him, Jeff had a reoccurrence of this disease. The last time Jeff reached out for treatment on demand, no bed was available. While awaiting treatment, Jeff turned to cocaine and had a coronary attack that left him brain dead. My husband, John, Jeff's brother, Tyler, and I made a decision that no family should have to make to take Jeff off life support. I share our family's story so that other parents and family members impacted by this disease may learn from our family struggles and find a successful path to recovery. I've spoken in public forums several times now. My first time was only 2.5 months after my son had passed. At that time I cried and I begged for treatment on demand. I still cry and I still beg for treatment on demand. But now I'm just a little bit more knowledgeable on what it takes to achieve recovery. Recovery can be obtained with an army of resources that employs an all-hands-on-deck approach and uses a roadmap to see where the roadblocks are and to find and/or build alternate routes to get to our ultimate destination, recovery. So, I earn a living as a scientist and I do investigations. So what does that mean? That means I'm often asked to process map problems and determine preventive and corrections to these problems so they won't repeat themselves. Today I'm going to share a roadmap that so many of our loved ones have traveled. I know it's kind of far away and kind of cheesy, but graphics is not my thing. But our loved ones are on this struggling road. They have substance use disorder, and they finally get to a point where they want to have some help. And they get to an intersection in the road and they make a choice. They make a decision. They reach out for a bed, treatment on demand. And if there's no treatment on demand, there's no bed available, they happen to detour off this road, getting from point A, which is a city of substance use, thank you, to this other place where they want to be living in recovery. So as they come down and make this, get to this intersection, if they can't get a bed, they often U-turn back into making poor choices or the effects of this disease. As they cycle in again, and this has happened to Jeff. Jeff went into rehab twice. He went into recovery treatment center twice. But the third time, as he matured through it, when he wanted to get recovery, that was no bed available, and ultimately, it resulted in death. All these children have lost their life to this disease. So how do we change this? How do we get to recovery? If we can get recovery resources, if we can build a bridge to get to the city that we want to get to, this city of recovery, this bridge has many of these resources up here. They're peer advocates, they're recovery high schools, they're support from their loving families, it's family support navigators. Everybody up here, this army, we need to have this in our community. If they get to a point where they ask for this help and this help is available for them, then they can ultimately get to this city of recovery. And this city of recovery, we have Megan, who's here. We have John, Cassidy. We have all these peer advocates that have reached this successful city of recovery. And there's so many paths to recovery, whether it's medication-assisted treatment, like Jeff had, and he had a wonderful year in recovery, and we reconnected. Collegiate recovery programs, peer engagement specialists. There's not just one path for each individual that's suffering from this disease. It's a mix, and it's a time continuum. It's prevention. It's treatment on demand. It's methadone if they need methadone. It's not methadone waiting for 9 months to get into the treatment program. It's not 3 weeks waiting to get a bed. It's not all of that. We have to support these things. I'm also a member, thank you. Good. I'm also a member of Friends of Recovery New York. And just last week, we went up and we asked for money from our legislators, assemblymen, and everybody up there, pleading for $42.7 million to support these, recovery services. And we need one recovery community outreach center in each county, of which, as of last week, there were 42 needed. We need recovery community organizations in each county. 43 were still needed. One youth clubhouse in each county in New York. 48 are still needed. 2 peer engagement specialists in each county. 96 are needed. And 2 family support navigators in each county. 103 are needed. If we could just bring a fraction of that to this city, to this town, to East Fishkill, where Jeff grew up. Jeff was in this courtroom. He's not here anymore. We need help. Thank you.
Lisa began the conversation about recovery with that, and for any of our panelists at the table, please feel free to use the mics that are at your table. If you're more comfortable sitting and speaking to the audience that way, that's absolutely fine. I'd like to introduce one of our panelists who just snuck in the back door because he just finished work, and I'm sure many of you are familiar with him, Dominic Tuminaro from Tuminaro's Pharmacy. Megan, would you share with the group who you are and what you do?
Hello, good evening. My name is Megan Hatfield, and I'm a peer engagement specialist for CAPE. But more importantly, I'm in long-term recovery. So what that means is I'm able to use my lived experience to meet people where they are in their journey. Sometimes that's the hospital, the emergency room. We also have recovery coaches that can meet people out in the community, wherever that may be. Just go for a walk with them, meet them for coffee. But the important thing is that, like Lisa said, there's not just one way to go about helping someone. There's multiple pathways of recovery, and it's our job to help people find the specific pathway that's going to best benefit them. It's our job to know what those pathways are and to help people find them. We really believe that the opposite of substance use disorder isn't necessarily just sobriety, it's human connection. And we really try to provide that human connection, that lived experience, kind of like a mentorship, to really help people and to give them, that personal guidance that they might need. So we have people, like I said, in the emergency rooms, Northern Dutchess Hospital, Vassar Hospital, Mid-Hudson Regional Hospital, and Putnam Hospital. So we're able to meet people there after they overdose or whatever they might be in there for as a result of their substance use disorder. So I want to thank all of you for making it your business to be here tonight. The stigma around this disease is loud and clear. There's a lot of misinformation out there that people are bad people trying to be good as opposed to sick people who are trying to get well. And you being here tonight is a big statement on your behalf that you really are seeking some answers and some solutions. And I think everyone up here agrees that, we'd like to help you find those solutions. So if there's anything you'd like to ask me in private afterwards or at the end, I'm here. I have lots of cards. Feel free. I'm an open book. Thank you so much.
Thank you, Megan. Nori and Kevin, I'd like the two of you to come up here and talk a little bit about the partnership between the East Fishkill Police Department and the Wappinger Central School District in terms of the coalition. And Kevin, could you give a bit of a backdrop of the criminal justice element and what's happening with our jails and that sort of backfill?
Okay, good evening, everybody. I'm Kevin Keefe. If you don't know me, I'm the Chief of Police here in East Fishkill. I know a lot of people look at the drug problem and they think it's a law enforcement problem specifically. And really, you know, we work just as hard trying to keep people out of jail as we do trying to put people into jail. We work closely with probation. We work closely with the school, especially when we're dealing with young people. And the school, of course, works with us when they have issues with kids who might be in crisis. And it's just very important that people understand the role of the police. We're in a very fine scale where we want to see people get help before they start committing crimes. We want to see people get identified and steered towards recovery before they've gone down that rabbit hole so far that now they're they go through a self-destruction phase where they start hurting themselves, hurting their families, and at some point they start victimizing neighbors, doing burglaries, doing other things to support their addiction. And we'd really like to see if we catch somebody for solely a possession charge. That's not necessarily a bad thing. It's a wake-up call. It's the only person right now they're hurting is themselves, and we want to see them get on the road to recovery. And at that point, our sympathies really do go towards the addicted person. We want to see them get help. But when they've gone so far down that rabbit hole that they're committing crimes to support themselves, our sympathies have to balance more towards the crime victims. And not that we don't want to see people get help, but obviously, we can't have, neighbors and people being victimized and not look out for their rights first. But it's just a very hard balancing act with the police. We really do want to see, we don't want to put people in jail that just have an addiction disease. So, and I know I kind of strayed off the topic here. I want to talk about how we do work with the schools very closely, and Nori can probably tell you more about that. But just so people understand the role of the police and where we kind of fit into this problem, and at least on the local level, we'll get back around to some of the things that law enforcement is doing, but I just wanted to plant that seed for you to think about before we go down the law enforcement side. But go ahead, Nori.
I just want the audience to know that Kevin is actually the treasurer for the Council on Addiction Education Prevention. He's on our Board of Trustees, as is Nori. Nori is vice president. So there is real collaboration within this community to address the problems that we're talking about tonight. And as I said at the very outset, all of these folks we work with on a regular basis. So when you leave here this evening, what we want you to be fully aware of is this problem isn't being addressed in isolation or in a vacuum. There is a real collaboration within our county and even beyond our county when we talk about High Watch, whom you'll hear about later. Everyone is actively involved in finding the solutions that will best serve the folks who live in our communities. Nori?
Good evening, everybody. So I see a lot of familiar faces in the audience. I have been living in Dutchess County since 1985, October of 1985. I purchased a home here and raised 2 children in this school district on the other side of town. But I am a Wappinger Central School District employee. I came back to teaching once my children were in school full-time in 1996 and went into administration in 2006. And at that time, Wappinger Central School District was already in contract with CAPE. In the 1980s, they became a contract agency, and they became a coalition advocate. They were signed a memorandum of agreement in 2014. Once I went into administration, luckily, thank God, Elaine was our student assistance counselor at John Jay at that time. And so I relied on her, she relied on me, and there were countless days where I was ringing her extension saying, "Stat, my office," and there would be a child in crisis. So the key component that forged our relationship was that we educated ourselves and understood addiction as a disease and have embraced the disease model, and through a lot of prevention education have been able to educate parents, educate other administrators, and the community at large in small doses. Yes, there's still much stigma, but the impact, see, if we understand it as a family disease, then we understand that everybody is affected. Yes, I knew and cared for Jeffrey, for Matt, for Jake, for Nick, for Craig, for Siobhan, for I don't know, I'm going to between 8 and 12 funerals a year. So we have to understand, and each of those names that I just listed have brothers and sisters, have mothers and fathers, have teachers that worked with them since they were entered the school district at the age of 5. So understanding that there's a social and emotional impact for the entire family. The disease manifests itself in other ways than the actual drinking or drugging. It affects all future relationships for that child, for that mother, that father, everybody connected to the person that's actually actively using. So we have to address the problem on all levels. The district just this year, after I think it was the most recent death that rocked the John Jay community, we started a support group for the siblings or for any other peer that is affected by this disease. And we're modeling it on the 12-step program, and with the help of our student assistance counselor. Are we going to hear from Megan later on? So I won't steal her thunder. But we, again, to address the stigma, to address this disease, is to talk about not only the onset of symptoms of the user, but every person that loves and cares about them. We all are affected. We all have this disease. Thank you.
So Megan and Jess, Nori gave you your entry. You may do it from there or come up to the podium. It's entirely up to you.
I think I'll sit here.
Okay.
Hi, everyone. I'm Megan Gerard. I'm at John Jay High School, and this is Jess Sirianni from Ketchum. CAPE employs student assistance counselors. We're prevention educators and counselors. We work in the high school. And the way that we roll out our programming for students is I go into the middle school. We do refusal skills with the 8th graders. We also do a program called Teen Intervene. That's a screening and brief intervention and referral to treatment program. So when students are referred to me through someone like an administrator like Nori, the student will come and see me, and we'll discuss really the most important thing I try to get across to these kids is there is no judgment coming from me. And I give them that sense through, my own experience. And I really hope that gets across. So I've been able to, I think I've been able to help some students, and they're helping one another. Now, we had just formed, we're calling it an Alateen-like group. So that seems to be growing every week with siblings of alcoholics and addicts. We have a couple of students who lost parents to this disease. You know, now that's something that we don't hear about a lot, but there's a lot of orphans, really, from this disease. And if I can be that voice for the parent, you know, when I'm speaking to these children and saying, your mother did not mean to leave you, I really think that they believe me. And anyway, the Alateen is just getting started, and we're hoping for more. I also would like to start a 12-step regular addicts and alcoholics group for after school. So I'll let Jess speak. There you go.
So I have the same position as Megan. I'm in Ketchum. We do Teen Intervene, which is a different type of program, but we also do what's called Project Success. It's an evidence-based program, a lot of individual counseling, one-on-one, but we also do the groups as well. So I'm not as far as you are with the Alateen, which is awesome, great ideas, but I am doing a COSAP group, which is Children of Alcoholics and addicts, and I have a lot of children, a lot of students who have parents in this county who are either an addict or have an addiction issue. So we do, again, a lot of the individual counseling and group counseling, but we also go into the classrooms and educate the students in their health classes and science rooms. Depending on what the teachers would like us to talk about. I've recently talked about vaping, because vaping is a big thing right now, but we've also done alcohol and drugs and marijuana and stuff in some of the classrooms, so.
Yeah, and we're both available for questions, or if you want to come and talk to us afterwards, we'll be happy to talk to anybody.
Thank you, ladies. Diane, they gave you your entry.
Oh, yeah, I heard that. Hi, I am with Tobacco Free Action Communities. We're over in Lake Katrine, but this is part of our area where we work. And so we are grant funded through the New York State Department of Health, and it's all about tobacco prevention. So we're over on the other end of things, along with you guys, just trying to prevent people from going down that road of addiction. And nicotine addiction being, you know, what we focus on. But because we also follow an evidence-based program, rather than providing a health message to young people, which is something they've heard already, we focus more on a counter-industry message, as well as on policy initiatives that have been adopted and are successful to prevent them from ever using tobacco. So that's one part of what we do. We also work with, other parts of our group work with multi-unit housing on tobacco policies. We work with open spaces on policies, as well as municipalities. We educate them and assist them as they look to strengthen their tobacco. Like in Dutchess County, there is a tobacco license, which was brought about in an effort to do the very same thing, to protect kids from ever getting addicted to nicotine. And I've heard, and there is some action on that right now, so we're hoping to see that that license might even be strengthened to raise the age to 21 for purchase of tobacco products. So that's something on the horizon to look out for. And tobacco being the #1 cause of preventable death is still such a huge problem, and it's also so completely tied in with all other forms of addiction. It tends to be one of the first drugs, nicotine, that a young person might try before they move on to other things, and they hold on to that addiction and then add others. So it's also very important to address that, and especially in treatment, to address the nicotine addiction as well. And then what's happening is we're seeing such a decline through all of these efforts, these population-based efforts that we've, tobacco people have been working on over the years, that really the news is very positive around combustible or smoked tobacco products. And the rates have gone down so low at this point. They're in the single digits as far as high school students go. Unfortunately, the flip side of that is the tobacco industry, like they say, a leopard never changes its spots, and they're here, and they're finding new ways to get people addicted to their products. So they're buying up these e-cigarette companies, and they're using all the same tactics that they used with tobacco that are now not legal. And since e-cigarettes are not very well regulated at this point, they're using these same tactics to get people addicted to their products. So one of the big things that's coming out now, and you might have heard about it, but I'll just mention a little bit, are these things called Juuls. And these are just really space-age kind of devices that kids, they fit in the palm of their hands. They're a huge problem in schools now. I think the rate of...
Tested that.
Yeah. And they have these little pods, they call them. They have all these cute little names, exciting colors and flavors that are very attractive to kids. And they're available online. They're available at all tobacco, a bunch of tobacco retailers. And they're all over YouTube videos about how to use them. And they're becoming such a problem that while we were in single digits with combustible tobacco, we're now at around 20% e-cigarette usage among high school students. So it's a serious issue that needs to be looked at. So that's what we're kind of doing, is we're kind of bringing this in, because every time we think we solve the problem, the tobacco industry comes at us with something else, and that's where we're at right now. So I'm also here, I'm working, and I hope to meet with some of you in the coming weeks to bring programming into the high schools, all about, this type of work, this prevention work that we do. Thank you.
Thank you.
Jean Marie, I think Diane just sort of gave you an entry into the prevention, and then from there, Jean, could you also encapsulate the treatment piece and the recovery piece from the county perspective, and then we can move on to your colleagues from the treatment world?
Sure. That's a loaded order there, Elaine. Thank you all for coming out tonight, and thank you for having me. My name is Jean Marie Niebor. I'm from the Dutchess County Department of Behavioral and Community Health. I'm the prevention coordinator, and I am now the director of the Opioid Overdose Prevention Program. So first, I'll talk a little bit about prevention efforts in the county. The county, Marcus Molinaro has really talked a lot about prevention lately, and he's been talking a lot about it as he moves through the county and discusses his initiatives. And it's something that he thinks is really important. And as such, he's given us some resources to be able to bring prevention and strengthen prevention efforts in the community. So we work with partner agencies such as CAPE. I attend the community coalition meetings, and we work within the schools and hospitals and colleges and other places where we can put forth prevention efforts. So some of the things that we do through the prevention is training. So we do mental health first aid and youth mental health first aid, which are really excellent 8-hour courses that work on helping people respond to mental health crisis. We do assist trainings. Those are also suicide prevention trainings, suicide safety for teachers, QPR, both suicide prevention. And we do the crisis intervention training, which is for police officers that help. It's a 40-hour training that teaches police officers and other first responders how to work with individuals who might be in substance use or mental health crisis. So another thing we do for prevention, and I guess it's sort of a crossover between prevention and treatment efforts, is we have something called the Opioid Task Force. And the Opioid Task Force is a collaborative of community partners that comes together quarterly, and we have multiple subgroups. And the subgroups are working on the opioid epidemic from a multi-pronged approach. One of those prongs is mobilizing community and grassroots supports, including the coalitions and the peer specialists and all the recovery coaches and all the wonderful folks who are doing really grassroots, on-the-ground efforts. We also work with the Interfaith Council to try to help bring this message into the faith-based communities throughout Dutchess County, and they've been extremely supportive and interactive with us as well. We have ongoing programs, we have ongoing problems too, but ongoing programs that work to divert individuals with substance use disorder out of jail and into supportive environments. So much like was being discussed earlier, we're really working very hard with local police departments. Right now, specific really to Poughkeepsie, we're focusing on our efforts there first. To get individuals transported pre-arrest to our Stabilization Center, which I'll talk about in a minute, to help get them connected to treatment as soon as possible or supports as soon as possible. We're working on closing gaps in treatment following discharge from inpatient. We know that that's a very high-risk time for individuals coming out of jail, and also coming out of inpatient treatment is a high-risk time for overdose. So we're working on making sure that recovery coaches, peer specialists, the mobile crisis intervention team can connect with those individuals very closely following their discharge from these programs to try to minimize the risk and address the level of need that they might be experiencing after coming out of one of those programs. We're working on training doctors, prescribers, and pharmacists in Dutchess County to expand the treatment network, to increase the number of doctors who are able to prescribe medication-assisted treatment in order to increase access to that. We're working with pharmacists to get them to use the NCAP and the ESAP programs, which work to help individuals be able to access Narcan at local pharmacies, as well as do needle exchange programs at local pharmacies. What else? And I think, so there's also something called the BEAT program, which is a mental health practitioner riding along with police officers in the community to help engage people who might be harder to reach in our communities. I've spoken to officers and people who have had contact with those officers and the clinicians that do that program. They call it the Nice Cop Bus, and they really like them. They look forward to talking to them, and they've really engaged some hard to reach people and gotten them some help. So that's a promising program as well. We also purchase prevention curriculums for schools that promote social emotional learning on the prevention end of things. So a program called Second Step, which is an evidence-based program, goes K through 8 and works on developing coping skills and other kinds of ways of dealing with stress and things like that. So in an effort to really help kids become resilient and hopefully develop into very good coping individuals. That's our goal. So that's pretty much all I have. And then in terms of resources, the county has several resources that, I think I've worked in multiple counties, and I feel really fortunate now to be here in Dutchess because we are really very resource rich in terms of what's available from the county level. We have the Stabilization Center at 230 North Road, which has been there for about a year now. We've served about 2,000 people, which is really a good number, but we look forward to expanding that. And one of the things, who here has, just by a show of hands, who's heard of the Stabilization Center? Okay, so, like any new program, it had some bumps in the road and continues to have bumps in the road, and we work on addressing those and making it the best program it could be. We really encourage and welcome any feedback that you've had as the community so that we can work to make that, as seamless as possible. But the Stabilization Center is a 24-hour day, 365-day-a-year center at 230 North Road that is open. It's a walk-in center for mental health and substance use crisis situations. So you can walk in there and get connected to support and help no matter what level you're at that point in time, whether you just want to sit in there for a couple of hours and have a hot shower and wash your clothes, or whether you are interested in getting into a treatment center, they can help connect you with that. Their goal is to try to get people into treatment within 24 hours. Individuals can stay at the center for 23 hours and 59 minutes. That is a licensing issue. But within that time, there are people there who are able to connect you to services such as Arms Acres that does inpatient care if that's what the individual is looking for. We have the mobile crisis intervention team that goes out throughout the county and assists individuals who are in crisis. We have the helpline, which is a 24-hour helpline that you can call and get mental health assistance right away. It's also the portal for all the other services. So if you are in need of an appointment for the Lexington Center for Recovery or Hudson Valley Mental Health or one of the contract agencies, you can go through helpline and they can get you set up with an appointment. The last service that the county offers is the trauma team. The trauma team is, I'm on the trauma team along with some other clinicians, and if there's a trauma in the community or an event in the community that needs some support, we are able to go out and offer that support, and that's in any capacity. So this morning I was at the River Haven homeless shelter for young people, and we just get phone calls where they say, something's happened in our community, whatever that community is. Can you please come over and give us some help? So the trauma team is there too, and that all can be accessed through helpline. Elaine, did I cover everything?
I think so, and all in one breath. That was. What I'd like to do now, Jean, because you did mention the work with the pharmacy, is put Dominic on the spot, which I'm sure he's going to be very appreciative of. What I'd like you to do, Dominic, just as a backdrop, we all know that we are here this evening having this conversation on the heels of a pharmaceutical industry that sort of opened the barn door and let the horses out, and there was no corral for them to go into. So back in the early 1990s, what ended up happening was we moved from palliative care, which was painkillers for helping folks with long-term terminal illnesses to make them comfortable, to pain management. And what I'm going to ask Dominic to talk about is what he saw from his perch as a pharmacist as that began to unfold in the late 1990s to where we are today.
Unaccustomed as I am to public speaking, and I didn't know I was going to speak. I also see Steve here from Hopewell Drugstore. He's also a pharmacist, and he probably shares some of the things we've seen. The one thing I want to say is I know we said some about adults, but we focus on kids, but I think I see the problem not only with kids. It's a universal problem. It's a problem with older people, and some of it, well, I'll say back in the 90s, we used to use a product, Percocet, or oxycodone with acetaminophen. Very rarely. It was used for very severe pain. And then I think one of the things that happened is doctors were told you're not treating pain enough. These people shouldn't have to have pain. And so we've seen an increase where I see now oxycodone for moderate pain. It's right on the prescription, used for moderate pain, and it's encouraged. And the people, I think I don't want to say only ones I feel sorry for. Some people have come in and said to me, I wish I could stop this, because now the pain is gone, but they're hooked, and they can't stop. And I don't, not to put fault on anyone, because I'm actually selling that stuff that's hurting. I saw my wife had knee surgery this past year, and she was encouraged to start taking the pills before she had the pain, so she would be able to get through that pain, and she wouldn't. She says, I could take an anti-inflammatory rather than a stronger painkiller, because they offered it to her right there. And I understand the reason. Nobody wants to feel pain, but the increase in the use of it has been drastic. I will say, since although there's still problems with it, since we've started the electronic prescriptions and the Istock program, it has cut down, because I think everybody, besides anything else, is a fear factor. There is a factor of with doctors, pharmacists, that I'm prescribing too much or I'm dispensing too much. But it has increased dramatically. I mean, I can't, I mean, I've been around a little bit, and I could see when we never used Percocet, and now it's commonly used. And I've said before, I've had people come in and say, I wish I could stop. And we do try to work with other stores, other pharmacies. If we see that someone, whether it be a young person or an adult, who we start to feel like they're abusing it, when they ask that they don't get it on insurance, they want to pay cash. And I used to say I didn't go to school to be a policeman, but in that area, I have to now become a policeman, and yet you have to use your conscience. You don't want a person to be in pain, on one hand, but on the other hand, you don't want it being abused either. So it's been a drastic change since even the 90s. I mean, it's tremendous, and I'm sure Steve could attest to that.
Is there anything you'd like to add to that?
No, I agree with what he was saying. Mike, please. Sorry?
Mike.
Well, I'll speak up.
Be loud.
I'm pretty loud. Yeah, but I agree with what you're saying. I remember back 80s, 90s, very rarely did you use that.
Right.
And now my narcotic cabinet is quite full, But I am starting to see a change, like with the Istock Program. People probably don't know what that is. That's where New York State is now monitoring people, and you can see, when they're going to get it, when they can get it. And they have me afraid now, just like with you. You don't want anybody to come, and the state is monitoring that. If I fill somebody's prescription 6 days early instead of 4 days, I don't want to be on anybody's radar to have them come and, why did you do this? I just opened my store here just about a year ago, and I had my 6-month DEA, the Drug Enforcement, come just to check to make sure I'm doing everything right. And they looked to see if, how many prescriptions I fill for narcotics, how many paid cash, how many was on insurance. So it was quite intense. He got about 20% through what I had, and he closed the book, and I'm thinking, oh my God, it just opened up. But I had passed, everything was fine. But it's just something to watch, you're right, So it is a big problem, I agree. Thank you.
With the Istock Program, we have to report any controlled substances every night to New York State. So if abuse is going on, at one time we used to say we're reporting it, does anybody look at it? But now we think they're looking at it because they all have computers and they know what's going on. So, and we have worked with the police at certain times, and we've given them a call, and it's, because you don't want to think of people as criminals, but on the other hand, you don't want to be forced to do something you don't feel comfortable doing.
We've eliminated the forged prescription
Right.
problems that
Yeah.
we're having.
Yeah, we used to get people who would come up from New York City with prescriptions, and they say they can't get this anywhere from New York City to here. Now that it's stopped, we don't see anybody from, the furthest away we'll see is, Wappingers or LaGrange, but we don't see anybody real far away.
Thank you, Dominic. Thank you. What I'd like to do now is take a brief minute to just rehash the 3 paths that are critically important as we move forward to address the problem that we're all here to talk about this evening. You've heard 3 words mentioned this evening: prevention, treatment, and recovery, and we're going to hear from our treatment folks next. You've heard Lisa and Megan talk about that there are multiple pathways to recovery, and that can include all 3 of those paths, or 1 or 2 of those paths. Every individual is going to find what works best for them, hopefully with the kind of support that you're hearing about here this evening. My colleague from across the river, Catholic Charities, is a prevention licensed organization, as is CAPE. We're licensed by the Office of Alcoholism and Substance Abuse Services as prevention agencies, and Dutchess County contracts with us for that reason. You've heard all of these folks talk about the collaborative efforts that are in place, That comes out of the coalition work that actually is the result of the federal grants that both Dawn and I have worked with through our respective agencies. And that is a model that's been used and adopted as we move forward to face these challenges. Now, last but certainly not least are the treatment folks that we want you to hear from tonight. You heard Lisa make mention when she opened up about the insurance challenges, and clearly there have been and remain insurance challenges attached to this disease. I'm going to direct your attention again to literature that is out on the table specific to insurance, how to help folks navigate those systems, in addition to the work of our peer engagement specialists and our recovery coaches. CAPE is fortunate within a week or two, CAPE will have 5 peer engagement specialists, recovery coaches. Megan and John, who you've heard made reference to, were actually the first folks in this county to begin delivering that service. Eric can talk a little bit about the regional collaborative that we're pulling together, which actually echoes what Jean Marie was talking about, to map out what are these new recovery services. Who are those folks? Where are they located? What are their hours of operation? What are they supposed to be doing? And how can we all work collectively together? With that, what I'd like to do now is start with Eric, and you guys can just move down the road there, talk about who you are, what your agency does, and in the email that I sent you folks, I asked you to talk just briefly, if you would, from each of your perspectives on the signs and symptoms, because that's very often a question that gets asked of us regarding this disease. Eric?
Sure. Thanks, Elaine, and good evening, everyone. Thank you so much for making it your business, as Megan said, to come here tonight and to get this information and participate in this conversation with us. My name is Eric Dentrone, and I'm the Associate Director of Regional Services for Arms Acres and Conifer Park. We're a relatively large inpatient and outpatient treatment provider in New York State. We're licensed by New York State Office of Alcoholism and Substance Abuse Services. We have Arms Acres in Carmel that has 184 inpatient beds. And then Conifer Park in upstate in Schenectady County that has an additional 205 beds. So we have 2 levels of care under our roof. Detox, as it's known now, is medically supervised withdrawal and stabilization. That's the level of care that we have there. So we do provide detox for those individuals who have opioid use disorders, alcohol use disorder, or sedative like benzos, Xanax, things like that, and they need stabilization in a medical setting. So we do offer that. And then we have inpatient rehab. And we work with both adults and adolescents. We work with kids from ages 12 up to 18. We actually can admit 19 and 20-year-olds also onto that unit when it is a good fit. By license, we're able to do that. Just a couple things about the program. It's a holistic treatment approach, so we look at the whole health of the person. We have an interdisciplinary treatment team, so we have medical staff on site, nursing 24 hours a day, and physicians, physician's assistants, and nurse practitioners, and psychiatry. So we're looking at the physical health, the mental health of the person. We can provide evaluations, psychiatric evaluations, initiate medications when appropriate for things like depression or post-traumatic stress disorder, bipolar disorder, as well as managing chronic illnesses. I mean, this is, everything is connected. So if you don't look at that piece, that could be a relapse trigger. If someone is not taking care of their physical health, as well as their mental health and their spiritual health. We have spirituality groups. We do also introduce people to the 12 steps in the evenings. We have outside meetings that come in so people get connected to peer supports. We do things like yoga and mindfulness, equine therapy. So there's many different ways to provide that treatment. You never know what might work, what might click for someone. So you have to kind of offer everything. So that would include medication-assisted treatment. That's something that we've been doing for a long time. We can do induction onto Suboxone or Vivitrol, and they connect them to continuing care in the community where they live. We also have an outpatient program in Carmel that last year we added the opioid treatment program, a methadone program, as well as Suboxone and Vivitrol. So we have the full range of options there in Carmel, which from here is maybe about 35 minutes away. So certainly the state And we recognized that there was a huge need for this in the Hudson Valley. There wasn't one in Putnam County, first of all, but certainly, our neighbors in Dutchess and in Ulster and Orange were overwhelmed by this opioid crisis. So, so we added that last year, and there's no wait right now. So for that. And those are our treatment programs in a nutshell. I'll speak a little bit about the signs and symptoms, and then pass it over to Jim. So in terms of substance use disorder, I know Elaine had asked me to speak about substance use disorder. A few years ago, our whole healthcare system moved over from identifying, addiction as not a dependency or abuse problem, but as a disorder. And that disorder basically exists on a continuum, that you can have a mild substance use disorder, moderate, or severe, based on certain criteria. And so those criteria, a couple of things that, that people could look for, I think, in terms of things to recognize, is because these things might be observable behaviors with someone, but there might be drastic changes in behavior. Someone gives up something that previously was of interest to them. That could be a really big warning sign. Something that they took great joy in, all of a sudden it doesn't matter to them. That could be a sign of, it could be a number of things, but that is actually one of the criteria in the substance use disorder criteria, as well as recurring use of a substance despite it having an impact on their physical well-being or psychological well-being. Someone developing tolerance to a substance, withdrawal. Withdrawal might be also observable symptoms that loved ones can see if someone feels physically sick or is experiencing nausea or a headache, things like that. So, that's just kind of scratching the surface, but I just, those are a couple things that people can certainly look for. And with that, I'll pass it over to James.
So my name is James. I'm a counselor at our Lexington Center for Recovery in the Adolescent and Adult Program in Dover Plains. Right now, Lexington has 6 different locations within Dutchess County, and actually one of the ones that we just opened a couple months ago was up in Wappingers, so relatively close by. Some of the common themes that kind of keep coming up tonight is that recovery doesn't happen in a vacuum, and that there's different pathways to recovery. So our counselors really try to work with our clients to understand that we can't just have a cookie-cutter approach to recovery, or to treatment. We really work on a person-centered approach where we want to listen to what the client wants to work on and kind of identify what they think is going to be the best view for treatment or best pathway to treatment, and then also help link them to different community providers or services in the area so that they don't feel alone and they have a team to kind of help them around them. So at Lexington, we offer individual as well as group therapy sessions. At most of our locations, they're 5 days a week, and Millbrook, they're right now for 2 days. But we have different groups that range from early recovery, providing some education around addiction, developing coping skills, and identifying triggers, as well as relapse prevention groups, and even groups for co-occurring disorders with mental health. So that'll be if anyone is struggling with PTSD or trauma, as well as working on emotion regulation and communication skills with dialectical behavioral therapy. So not only do we have the adult program, but we also offer an adolescent program that goes up into age 21. And within that program, our counselors are able to meet with our clients out in the community and also offer different community events. We actually just had one recently at the Culinary Institute of America, where all our clients from Dutchess County got to get together for team building and as well as lunch. So as well as just the treatment program, we offer psychiatric services located in our Page Park location to help with any co-occurring disorders or medication management, as well as medicated assistance treatment with our methadone program, with our methadone clinic in Poughkeepsie, and Suboxone and Vivitrol program in our Page Park location in Poughkeepsie. So a full range of services, and again, just trying to help link people with different, community providers and supports.
Thank you, James. Cynthia?
Good afternoon, or good evening. Thank you for having me, Elaine. And my name is Cynthia Flint, and I am the outreach coordinator for High Watch Recovery Center in Kent, Connecticut. High Watch is an alcohol and substance abuse inpatient facility. We are dual diagnosis, which means we treat co-occurring disorders. I probably don't have to tell a lot of you, but there is usually an underlying issue as to why someone is using, whether it be anxiety, depression, bipolar, post-traumatic stress. And the way that we treat the substance use disorder is through our 12-step principles, which is our treatment, and the medical side, which is the underlying issue. So we marry them together, and it really allows for a nice opportunity for the patient to begin a recovery, treating both. So through our medical team, we have medical doctors, APRNs, licensed clinical therapists, social workers, who really come together to be able to provide the medical treatment that the patient would need to go from treating the inside out, because there is an underlying issue most of the time, and in order to treat that, we need to work on that, as you know, so many were saying that. It's important to do that way. We at Highwatch do believe that addiction is a family disease, so we also treat the family as part of our program. And we do that through a family weekend, and when the patient arrives to Highwatch, they have a full biopsychosocial evaluation, and they are assigned a licensed clinical therapist. At that point, they're also strongly encouraged to schedule family meetings with their loved one as many times as they need throughout their stay. So it's important to have the family on board, because it is a family disease, and once the family and the loved one get together and realize, you know, that it is a family disease, everyone's on board at the exit of rehab to be able to, you know, go beyond that.
Thank you, Cynthia. So before we move into the Narcan training, what I would just like to provide a bit of a summary. Our purpose here this evening was to be able to present you with a lot of information. We hope we haven't overwhelmed you, but given the nature of the challenge ahead of us, the more that everyone knows, the better off we will all be. And as you can see by the extent of our panel, there are a whole lot of different perspectives and services that are available for individuals and families within our Dutchess County communities. That being said, what I'd like to do is give my Catholic Charities partner a shout out and let you folks know that in every county in New York State, there are OASAS licensed prevention providers. Those are probably a good landing spot as questions emerge regarding anything to do with this disease. We provide information, referral, education, recovery and peer engagement, short-term intervention, as was discussed by the CAPE counselors. We work closely with our federally subsidized coalitions, which actually have served as the model for bringing these kinds of community collectives together. So if anyone leaves here this evening and a question is generated by what you've heard here this evening, please feel free to reach out to us. If you have folks, we know that borders are porous, they're not finite. So if you know someone who's in Orange County or Ulster County, all you need to do is look up the Prevention Council in that area. We are a resource to connect you to all of these kinds of people seated on this panel. From the prevention end to the treatment end to the recovery end. And lately we've become very fortunate in that we have received a lion's share of funding from New York State OASAS to provide the peer engagement and the recovery services and the family navigator services that you have heard about this evening. So with that being said, I'd like to open it up to some questions. We've got, you know, quite a large brain, if you will, that's here with us tonight, a collective brain, and we would like to give you the opportunity to ask any of our panelists a question. And as Megan had mentioned in the beginning, if there's something more private that you would like to talk about aside, we can do that out in the area out here once the Narcan training starts. So questions? Yes, Judy. Hold on, Judy? Or else I'll get yelled at by the video gentleman.
What are the statistics that you have on the recovery rate, like of, let's say, I'm particularly interested in heroin. I assume, and I've heard, but I don't really know, it is not very high.
You're looking at me.
You're looking at any of you really don't have any idea, you know, the deal in that.
Let's use this one.
We hear so much, it's so low, it's this or that, I don't know. I know my experience was not good.
Yeah, I do know, I could speak for Arms Acres and Conifer Park. I mean, we're moving towards an age in healthcare where data and statistics are becoming more and more important for how we do everything. So we are, we have outcome studies. We don't have long-term outcome studies with our patient population. We basically, our role as at least an inpatient provider is, we're stabilizing the person, all aspects of their, of the acuity of what's going on, their physical health, mental health, as I mentioned earlier, and then connecting to the next level of care. So that's how we are that's how we measure success, is like, did they complete treatment and did they make it to the next program? And those are the studies that we have. So we don't have follow-up studies with our patients 6 months, 1 year down the road. We just don't have that information. It's very difficult to stay in touch with patients for long periods of time to do accurate studies, really. But I do know that we have a very high rate of patients completing treatment. That's about 85–90% of our patients that come to our program complete the program. In terms of making the next level of care, I mean, there 80. I think the last studies were like about 85% are given an appointment within 7 days of their discharge. That's a very low bar, if you ask me. But that's what the state and other governing bodies are asking for. In terms of making it to the next program, that's about 50% make it to their outpatient appointment. That's a major gap right now that we have in our, in terms of that space in between, that right now the state is really throwing a lot of resources to correct. So
they don't really have a statistic, I understand what you're saying for your treatment thing.
Yeah.
But, people get out, they go to treatment, maybe successfully complete your program, and then down the line they're in another program. I'm talking about people that are known that they had heroin problem, and whether it be a year, 2 years, or whatever, they don't overcome it, and they pass on.
Right.
And I mean, I hear that it's very low. I know in my case, my daughter was in many places and was successful and maybe was good for 2 years. Just before she had passed away, she was clean for a year and a half. And within 2 weeks, that was it. So it's just, you hear that the statistics are not high for recovering and succeeding and going on for your lifetime.
So, yes, we do have long-term recovery, and I want to commend you for being the brave soul that took that question, Eric. And I want to make sure he comes back and joins me on future panels. So that being said, what I'd like to do is capitalize on the fact that this is an all-hands-on-deck approach that is now happening. One of the terms you've heard bandied about this evening is evidence-based, outcome-based. Over the course of the last several years, many of the folks here who offer programming have to now march to the tune of federal and state-regulated evidence-based services, which will begin to collect the data that is lacking in terms of following the kinds of statistics that you would like to see, Judy. We are in the midst of an unprecedented public health crisis, one that is historic. No one has seen this in our history in this country before. That being said, prevention, treatment, and recovery are all being asked to do more and more and more in the face of this epidemic. And I would offer that over the course of probably the next 5 years, given the impetus to actually address this in a very robust way, we're going to see more hard and fast data that will measure the work that prevention is doing, treatment is doing, and recovery is doing. Do you think that's a fair assessment?
Yeah, absolutely.
That's right.
Well, that's perfect. You're talking about the nature of the disease itself.
Chronic illness.
Yes. Which, if we think about addiction as the disease that we're labeling it, we all are familiar with many other diseases. And believe it or not, once not too long ago, Judy, I was taking a look at relapse for diseases in general. Addiction is not at the top of the list. Heart disease, diabetes, hypertension actually surpass relapse rates of addiction. And it goes hand in hand with the disease model. We can all have a disease and we can relapse from it. And addiction is no exception. But what our state is trying to focus on is the hope of recovery and the initiatives that we're putting in place in terms of helping individuals find their multiple pathways to recovery. Any other questions? Yes, ma'am.
I have a question, and kudos. Let me tell you, what you're doing is phenomenal. My question to you, especially, when we get to the hospital, after working on somebody that is dead, overdosed, we bring them back, how long does it take to get into any of these programs? Because many times, I see them out on the street a day or two later.
They might refuse.
So where do all of these fantastic programs fit into something like that once they leave the ER?
Megan, can I hand that to you?
Sure. So, first of all, the individual has to want the help, because
I'm talking 17, 16, 33, 60-year-olds.
Right.
These are, and many more that I've worked on. And thank God I've brought them back. But where do these programs, do they have to go to you? The younger kids that are under, now, how old do they have to be to get into these programs? Is it the parents with the 16, the 17-year-olds?
So there are adolescent programs like Eric mentioned, and the gentleman from Lexington. There are places for adolescents to go as well as adults. Depending on the hospital you bring them, some of the hospitals have detox inside. Vassar does not.
Okay.
So it's up to the social worker to help them either get transported to the Stabilization Center where they can then get referrals to a higher level of care.
Okay.
But they're going to be medically discharged after an overdose if they're okay, if they would like to be. It's up to them. I face the same difficulty. If the individual wants to leave and they're medically cleared to leave, they're allowed to walk out the door. But what we try to do, and keep in mind there's 2 of us in 3 hospitals and 24 hours a day and 7 days a week, but we try our best when someone is willing. We try our best to speak with them because I see a lot of the same folks as well, and try to kind of leverage my lived experience to help them maybe try something different. And most importantly, meet them where they are and be willing to help them until they're ready. So oftentimes I'll meet someone in the emergency room. They're not willing that day, but I get a call like 3 weeks later at 10 o'clock at night. Miss, you probably don't remember me, but I'm ready, I want some help. And then we can get them over to the Stabilization Center and then over to Arms Acres or Lexington or the most appropriate place. But your frustration, I understand.
Okay.
It's
to add to, does the hospital get in touch or give any of this information to the patients?
Well, some do. They are aware of our services. We have provided them with cards and pamphlets. It's a very new program. I will say that we're not available 24/7 necessarily in person in the hospital, and there's only 2 of us with so many hospitals. But we do get frequent calls, and we are able to give information referrals over the phone. So I guess the solution would be for me to give you some of my cards, and I'd be more than happy to talk with any individual you come across that you think might be willing to have a conversation with someone.
Oh, I'll take a couple of dozen.
Yeah, so we can start there.
Jean, did you want to weigh in on any of that?
Well,
I don't want to put you on the spot.
No, it's okay. I think Megan did a really good job of addressing the question. I would say, as a clinician, I having years been on the treatment end of things and not the prevention end of things, I know how how hard it can be to see someone that you want to get better but isn't quite ready to do that yet. And it really has to be about when they're ready to go. That's why it's so critical that we have people like Megan out in the community, because when they do say, okay, I'm ready, that we can then, get them to where they want to be.
But it's a shame that the hospitals aren't doing more.
So we do have hospitals attending our opioid task force at the county, and it's something we're working on because
They're not in the ER, and somebody isn't there when we are bringing the patients into them.
yeah, so
Which, to me,
it's definitely part of the gap. It's definitely part of the gap, and I think the best way to do it, I think emergency rooms are a really busy place, and there's a ton of staff, and there's a ton of people coming in and out. So the struggles are who's going to give that information, how are they going to give it to the person, when are they going to give it to the person, and sometimes the person just gets up and leaves, So it's a complicated system, but it's definitely an area that needs to be improved.
Lisa, you wanted to say something?
It's, we would all like to have the ideal resource there, the money paid. It's not going to be there, so it's a community. I'm sorry. It's this community that has to get Megan's cards, has to get John's cards, has to get the Cape cards, has to get Matt Foundation, has to get everybody to know everything that we're talking about right here. It's all about communication. Between being on instant dial, I have gotten referrals from at least 5 different families within the last 2 months. I have a full-time job, but my commitment is also to give this message. And with that, I'm writing my notes down. So the next time I go to my support group, my role in my support group is different now. I don't need to go to my support group anymore to save Jeff, but I could save somebody else by saying, here's this group. I got now 5 more contacts that I can do. We have to start it here. You have to communicate out that way, because you're not going to get that resource at this point. We can't save them all. It's going to be when they are ready, and that's what we can do.
It takes a village.
She hugs me all the time.
It clearly takes a village, and I think, I'm coming to you next. I have to echo what Lisa just said. It will take a community-wide response to push back on the stigma, to make our needs known to our policymakers, one of whom is present tonight from Senator Serino's office. We have to be able to deliver our needs to the policymakers who have the ability to make the kinds of resource changes that Lisa is making reference to.
Can I add something real quick?
Sure,
to what you're
Eric.
saying? So, because it's 2 things that I think that, with what you're talking about, in that situation, when someone's revived with Narcan and they're brought to Vassar, for example, there are 2 things that need to happen. Number 1, access to services, the on-demand that Lisa spoke about earlier. All that someone has to do is call, for example, Arms Acres. I mean, if that call is made, and if we have a bed available, then we'll come and pick them up from that ED, from that emergency department. But someone's got to make that call. There has to be somebody that knows to do that, and that's something that, as a system, we can speak to Vassar and say, listen, there's an issue here. There's some disconnect that needs attention, whether it's Arms Acres or other programs that they can be sent to. Access, do we actually have a bed? Sometimes we don't. And we're full. I mean, we are fairly large, so we have 31 detox beds in Carmel. We also have 34 upstate if we don't, so we have a little bit of flexibility. And that's where I think the Stabilization Center is a tremendous resource, for that gap, because oftentimes we don't have one today, but we have one tomorrow. So if they can be brought to Stabilization Center, we can get them from there.
Okay, can I interrupt one
Yeah.
second?
Yeah.
One more thing to add to this. Now, my nephew is in recovery. This has been going on for almost 6, 7 years now. Knock on wood, he's doing good. He's going to school to be a counselor for drugs. Okay. What fought them and gave them the biggest trouble was insurances.
Right.
They're the ones that did a job most of the time. My brother and my sister-in-law, they could not handle, money-wise, these great places to send him.
Right.
And the places that could were dirtbag holes, which he was almost worse coming out of. So
Cynthia, I'm going to put you on the spot because you talked to me recently about some changes that had occurred at High Watch and scholarships and such. Can you address that a little bit?
So at High Watch, we had been self-pay since 1940. We've been in existence since 1940, and as of last year, we're now able to participate with private or commercial insurances. We have been seeing success with insurance companies allowing the stays. And what was the other thing that you had mentioned?
Scholarships.
Oh, scholarship, yes. So High Watch gives about $6 million worth of care a year away. Worth of care. So we do have scholarship opportunities available. We also have an extended guest program that says if a patient is with us for 38 days, they'll then have a week for free, which is the care that we give, bringing them to 45 days. Then at that point, they're also encouraged to apply for an extended guest program, which we have 8 beds for, which gives them an additional 45 days of care absolutely free. Their level of care does not change, but it brings them closer to that 100-day mark that NIDA recommends as optimal care for inpatient. Really, I mean, the length of stay is so critical to success as well. It really is. So yeah, so there are opportunities for scholarships. I mean, I'm sure that you all have scholarship beds available as well.
So
you know.
thank you, Cynthia. What I'd like to do, did you have something you wanted to say?
Hear everybody, and yes, insurance is, do I need a microphone? Insurance is definitely an issue, and we have seen an itty bit of reform, but there's also not enough rehab facilities that people can afford or to get people into. What you're doing is great. We need a bazillion more, and I think with all these services haven't been there forever. So this is a peer engagement specialist. That is amazing to me. I mean, I've never heard of that. So I just feel like we have a long way to go, and everybody's going to be very frustrated, and everybody has their story. It's going to be a long time.
Thank you for that. We are making progress, and it is inch by inch. And the recovery and peer engagement is really relatively new. Yes, ma'am. I'm going to have to, or my New York National Guard partner is going to take me outside and have a few words with me because Narcan training is waiting. So we'll take one more question. Yes.
First of all, I'd like to thank everybody for coming. Elaine, you're a fantastic speaker and fantastic organizer of your thoughts. I've heard everything, but what we haven't talked about is the aftercare when they get out of a rehab, when they get out of jail. Where do they go? They can't go back to their neighborhoods. They can't go back to their friends. They struggle. Where do they go then? We need places for them to go.
Recovery Center.
Megan, do you want to take that and maybe pass it off with Lisa and briefly talk about Friends of Recovery and the advocacy that we need to do as a community?
Sure. So we have a grassroots advocacy group, which you've attended, called Friends of Recovery Dutchess, part of a bigger group in New York. And we do a lot of advocacy around having places such as this. There are places throughout the state called Recovery Community Outreach Centers, which provide a place for people to come after treatment to find the multiple pathways to recovery that we keep speaking about. Because, you know, we're all familiar with 12-step recovery. That's been around for quite a while. But it's an exciting time for recovery because now there's other things. Unfortunately, they're not very accessible because we don't have like a central hub really in our area. So that's one of the things we've been kind of rooting for to get funding for in our area so that people do have a place to go to find recovery coaches, multiple pathways to recovery support groups, help with resume building, you know, a running club, a yoga class, you know, you name it. This can be a place to get a lot of supports. So you bring up a really valid point, also something that we are definitely fighting for right now. So that's another thing. Anyone here can get involved with our group. We meet the first Wednesday of every month, and you know, we fight for these services that are greatly and desperately needed in our community.
And in closing, what CAPE has done, which Megan has alluded to and Nori sort of whispered out of the corner of her mouth, CAPE has recently submitted to the state a request for consideration of a recovery high school in tandem with a recovery center. That process is moving slowly. As a matter of fact, Nori and Kevin will be at our stakeholders meeting tomorrow. We're supposed to be able to roll out to OASAS a more fully fledged proposal. We have had one telephone conference with them back about a month ago. Nori and I visited an actual recovery high school in operation in Rhode Island, and we've been in conversation with a nationally accredited one in Texas to inform the proposal that we're hoping to put before OASAS. So there are a lot of people taking a long, hard look at what our community needs, and there are multiple stakeholders at the table to do that. As a matter of fact, Senator Serino's office, along with many of our policymakers, will be part of our stakeholder meeting tomorrow. It's the second in our series. We have Mayor Matt Alexander from Wappingers. We have the superintendent of Wappingers, the president of Dutchess Community College, the superintendent of BOCES, Kevin, Nori, Congressman Maloney's office sits as a stakeholder on that. So everyone is taking this issue very, very seriously. The problem is change comes slowly. But we are very hopeful, as is the whole recovery community, that with a growing number of people, your call to action when you leave here tonight is to tell one or two more people about what you heard here this evening, how this is a disease, how there are services that our county offers, how can you get to those services, how can you talk to a peer engagement specialist, how can you get to the treatment needs that you have. Getting people to where they need to be puts them on the path to their recovery path. And that's what we need to do collectively as a community. That being said, what I'd like to do is invite our panelists who are not part of the Narcan training, if they don't mind, to step outside, and if there are any additional questions that we have not been able to address in this forum, I'm sure these folks would be happy to talk with you. In the meantime, anyone who is here, we have enough Narcan kits to train anybody here this evening who would like that. And with that, I'd like to introduce Sergeant Fernandez. Sure. And I would also like to thank Kevin, because without Kevin, this event would not have happened this evening. He reached out to me and said, Elaine, we need to do another forum. So a round of applause for our panelists and for Kevin.
Hi, folks. I just want to mention, I know on our flyer we noted that we were going to have our drug disposal box here for anyone that may have brought any excess or old medications to get rid of. There's a green box right outside the door. There's baggies on top. If you did happen to bring anything, pour your bottle of meds in the baggie, put it in the bin. We don't want people's bottles with their personal information. We want you guys to dispose of that. But if you have something, any other day of the week, 24/7, you can come down to the police station. It's in the lobby of the police station. Totally anonymous. Just tell the dispatcher you're here to drop off meds. We don't need to know your name. We just want to know that somebody put something in the box so we know when we have to empty it out. So, but it's here if anyone needs it. And here you go, Sergeant. Oh, yeah.
So now I'm going to turn this over to Sergeant Fernandez, and anybody who is here who wants to be part of this Narcan training is welcome to stay. Sergeant?
Is that everybody? Is that everybody? Who wants to leave? Let's be honest. It's like 5 liars in this room right now. Oh, there we go.